Hi, everybody, and welcome to our debate regarding alternative models to address quality of care with children with ASD. My name is Erin, and I will begin today by introducing the members of our debate team. As I said, my name is Erin Gus, and I currently live in Ames, Iowa, and I'll be moderating the debate as well as taking questions from the audience at the end. Next up, we have Jacqueline Haskut from Northern New Jersey, who will be discussing the advantages of the medical model. Finally, following Jacqueline, Deborah Michaels, also from New Jersey, will introduce us to sensory integration therapy and the benefits it offers to children with ASD. Finally, Ina Kennedy from California will discuss applied behavior analysis and the advantages it presents. We will be discussing each topic individually and then continuing into a question and answer session. The purpose of this debate is not only to explore 3 commonly used behavioral therapies, but also gain insight into the pros and cons of each. Jacqueline, can you please begin by discussing the advantages of the medical model for us?
Thank you, Erin. So should treating a broken bone be treated the same way as a mental disorder? According to the medical model, yes, it should. Instead of psychologists adapting this idea, it was created by psychiatrists. The belief behind the medical model is that eventually there will be an appropriate treatment discovered and administered to cure the syndrome. Some of the main focus points for the medical model approach are genetics, neurotransmitters, neuropsychology, and neuroanatomy. Overall, this approach states that mental disorders are linked to the physical structure and functioning of the brain. So a study was done to systematically review evidence regarding medical treatments for children ages 12 and under that are diagnosed with autism spectrum disorder. In this study, different databases such as Medline, PsycInfo, and ERIC were searched by 2 reviewers. They extracted the data regarding intervention characteristics, assessment techniques, and outcomes. The results of this study supports 2 medicines, risperidone and aripiprazole, are good to use for challenging and repetitive behaviors in children with autism. So the medicines that are used are also used to treat mood disorders, and within ASD, challenging behaviors such as irritability, aggressions, and self-injurious behaviors. So the advantages of the medical model are they attempt to reduce symptoms of autism. So an article published by CAP in 2013 stated that the medical model aspires towards normalization, symptom reduction, and elimination of conditions identified based on deficits to cause functional impairment in major life activities. Although there are many treatments that can be used for autism, they all target different skills. For example, educational models attempt to increase academic and functional skills. The medical model attempts to reduce symptoms of the disorder while also increasing independent living for that individual. This leads me into the second advantage. Increasing independence is a goal that every parent wants for their child. If symptoms of a disease or disorder can be reduced, there is a higher chance that the individual will show an increase in their independence. With a decrease in symptoms or no signs of symptoms at all, there will be nothing in the way of the individual's life. Finally, the medical model does not only consist of administering medicine to individuals. There are also therapeutic interventions such as behavior therapy and counseling as well. With medicine, counseling, and therapy, the individual will benefit most from the medical model. So when treating a child with autism, one ethical principle that needs to be taken into consideration is Code 3.02, medical consultation. This code states that behavior analysts recommend seeking a medical consultation if there is any reasonable possibility that a referred behavior is influenced by medical or biological variables. It is important to involve parents in decision-making regarding medicine. Additionally, it is important to make sure that all involved understand what is being discussed regarding the different variables, such as the dosage of the medicine and the different medications that can be used. Another code that should be considered is 4.02, involving clients in planning and consent. This code states that behavior analysts involve client in planning of the consent for behavior change programs. Similarly to Code 3.02, it is important to involve parents and the child's team in all decisions regarding the planning and implementation of the child's programs, behavior plans, and medicine. The last code that should be considered is Code 4.03, Individualized Behavior Change Programs. Part A of this code states that behavior analysts must tailor behavior change programs to the unique behaviors, environmental variables, assessment results, and goals of each client. Part B states that the behavior analysis do not plagiarize other professionals' behavior change programs. It is important that each behavior change program is catered individually to the child, and decisions are made based on the child's allergies, height, weight, and other circumstances.
Thank you, Jacqueline. Now we're going to open the floor for any questions or comments about the medical model.
I have a question. So, Jacqueline, you just said that the medical model attempts to reduce the symptoms of autism by medicating individuals who have been diagnosed with autism. So my question is, how does the medical model take into account the wide variety in symptoms and severity that is shown through the autism spectrum? So does the medical model suggest that they are all treated the same way?
Thank you for your question. Although the medical model intends to be able to use medicine to reduce the symptoms of autism, it does not suggest that a single treatment is correct for all symptoms. Ritvo, Edward, and Freeman suggest multiple subtypes of autism spectrum disorder, as well as several possible pathological processes for treating those subtypes.
Okay, I have a question too. How can this medical model take into account Ethical Compliance Code 4.03? I know you mentioned it, but in Ethics for Behavior Analysts, Bailey and Birch state that behavior analysts must tailor behavior change programs to the unique behaviors, environmental variables, assessment results, and the goals of each client. Can you say that this ethical principle is upheld when using the medical model?
Yes, because although there are differences in the way autism presents itself in individuals, research shows over 75% of all people with autism have severe enough neurological damage to cognitive areas in their brains to test mentally disabled for the course of their life. Furthermore, research shows that autism occurs within the same incidence throughout the world in all social classes, all types of families, and in remarkably similar clinical form. Although other therapies like applied behavior analysis create individualized plans to correct certain areas of the behavior, the medical model instead seeks to find a treatment that can overall lessen the symptoms caused by it.
Okay, but I do have some concern regarding the reliability of the medical model. So there was a study conducted to determine if psychiatrists can reliably distinguish between people who were mentally ill and the people who were not. McLeod states that the results from this study show that psychiatrists were only able to diagnose 41 out of 193 people as being mentally ill, when really all patients were diagnosed prior to the study. If diagnosing has been shown to be such an issue, how can you say the medical model can be reliably used?
Thank you for your question. Although diagnosis is an issue, technology as well as diagnostic criteria has highly improved recently. A study by CAP states that many parents, professionals, and the lay of the public support the medical model by categorizing autism as a disease or an epidemic. This is based on the rise in number of diagnoses. The increase in the effective diagnosis can also attribute towards the expanded diagnostic criteria.
Perfect. Thank you, Jacqueline. And thank you for your questions, everybody. We're going to move on to Deborah, and she's going to explain to us the sensory integration model.
Thank you, Erin. So let's first talk about what is the sensory integration therapy, also called SIT. SIT was developed by an occupational therapist, Jean Jaurès, in the 1970s. So he believed that children with learning disorders may have sort of a neurological problems related to processing sensory stimuli. And because of the brain plasticity, he thought that providing specific form of sensory stimulation in an appropriate dosage will improve the nervous system of those children. So in other words, he wanted to train individuals' nervous system to allow them to better process sensory stimuli. So you can wonder how SIT is used with individuals with autism. So professionals working with individuals with autism see a lot of advantages in using SIT. First, its main goal is to teach the nervous system how to process sensory stimuli. And as we know, a lot of individuals with autism often overreact or underreact to sensory stimuli, like the loud noise, light touch, the texture of some object or fabrics. So by using SIT therapists, most of the time those therapists are occupational therapists. They propose activities that improve the sensory system by providing vestibular, proprioceptive, auditory, and tactile stimuli. They are using a lot of tools for that, like brushes, weighted vest, swing, scooter board, and other things like that. Everything that stimulates the sensory system. So for example, if an individual is having problems with tactile stimuli, the therapist may work with him to get used to be touched by starting with light touch and very soft brushes, and then firmer touch and so on until the individual reacts properly to the stimulation. Another advantage of SIT is that it can be individualized to each individual's needs and preferences. So for example, therapists are going to use weighted vests and brushes for tactile stimuli, and swings and scooter boards for proprioceptive stimuli. SIT is also a great therapy to work on motor skills. Karim and Mohamed found in their study that individuals with autism that have coordination issues can improve their coordination by using SIT. So for example, therapists can work with those individuals by asking them to grab different objects of different sizes, and that is going to improve the fine motor skills. The therapist can also use swing and big ball to work on balance and gross motor skills. Finally, occupational therapists use SIT to support children in their learning process of writing and reading. So, for example, a lot of children with autism have difficulties writing because they have a hard time holding pencil correctly. So therapists can teach them how to develop and maintain an effective and proper pencil grip. So in this graph, that's a graph taken from the study of Karim and Mohamed, and it's showing that the effect of SIT when treating fine and gross motor skills of young children. So you can see that there is an effect after the pre-treatment. You can see the effect of the post-treatment in red. And this graph is more specific. You can see all the details of the fine motor and gross motor they tested. Of course, there are a few ethic codes that need to be taken into consideration when using this model. First, the code 1.01, so reliance on scientific knowledge. A lot of studies measure the effect of SIT on individuals with disabilities, and a few of them do it on individuals with autism. We can also consider the code 2.09, sorry, treatment and intervention efficacy. So studies have shown that sensory integration therapy can be used specifically to benefit children with autism by improving their gross and fine motor skills, like the locomotion, manipulating objects, etc. Plus, it's helping them to process sensory input more appropriately. So, for example, they can tolerate loud sounds better and discriminating sensory stimuli more accurately.
Thank you, Deborah. We're going to open up the floor for questions and responses again.
Okay, so I have a question. This research seems to show great progress by using sensory integration therapy to increase motor function. However, according to Leiden in 2017, the studies that measure sensory integration therapy tend to not measure behavior directly, which is in contrast with ABA. Lang also didn't find any consistent positive effect for SIT as a treatment for children with autism. Do you have any evidence to show that sensory integration therapy alone can be effective for treating the multitude of symptoms that are generally present with children with autism?
Thank you for your question. The sensory integration therapy seeks to advance the senses of the individual and does not try to work as a singular treatment for all the symptoms of autism. Fazloglu and Baran state that it's through their sensory experiences that children develop a connectedness to the rest of the world. Therefore, when children show a sensory dysfunction, it's harder for them to learn within the world. So we just stick to use sensory integration as a fun and inviting way to stimulate children's brain to help their sensory and motor skills become more developed.
Okay, great. I have one question too. If sensory integration therapy is used to train individuals' nervous systems, how does it take into account their individuality and preferences? Does the treatment tend to have all individuals reacting the same way to sensory stimuli?
So, thank you for your question. The sensory integration therapy is used to improve the reaction of individuals that underreact or overreact to sensory stimuli. So Perham and his colleagues precise that therapists using SIT support each child's motivation to play They create a setting that supports play as a way to fully engage the child in the intervention within a mutually enjoyable partnership. And that partnership means that therapists adapt and individualize that intervention for each individual, considering their needs and preferences.
Thank you so much, Deborah, for all that information, and thank you for the questions. We are going to move on to Ina and the applied behavior analysis model. Ina?
Okay, so applied behavior analysis incorporates procedures that strengthen desired behaviors and they can decrease undesired and maladaptive behaviors. And they are utilized in the context of a careful and individualized plan of intervention based on observation of the individual. It is not an experimental or investigational procedure. It is clear from articles like those by Finn and Watson that behavioral interventions can significantly facilitate acquisition of language, social, and other skills, and that behavioral improvement is helpful in reducing levels of parental stress. Among the many methods available for treatment and education of people with autism, applied behavior analysis, or ABA, has become widely accepted as an effective treatment. 40 years of single-subject design research testifies to the efficacy of time-limited, focused applied behavior analysis methods in reducing or eliminating specific problem behaviors and in teaching new skills to children and adults with autism or other developmental disorders. So children who receive early intensive behavioral treatment have been shown to make substantial and sustained gains in IQ, language, academic performance, and adaptive behavior, as well as some measures of social behavior. And their outcomes have been significantly better than those of children in control groups. According to many state departments of health, it is recommended that principles of applied behavior analysis and behavior intervention strategies be included as an important element of any intervention program for young children with autism. These methods build on a large body of research on the application of learning principles to the education of children with autism and related conditions. Many forms of ABA, such as comprehensive behavioral treatment for young children, early intensive behavioral and developmental approaches, and focused behavioral interventions have been shown to be effective treatments for autism. So ABA is also considered an evidence-based practice, which means a practice that relies on scientific evidence for guidance and decision-making. Practices that are not evidence-based may rely on tradition, intuition, or other unproven methods. Since the early 1970s, ABA has been studied and used to intervene with socially unacceptable and harmful behaviors in those with autism, as well as other behavioral disorders and problems. This method can be used at home, in school, and any other number of natural environments for the client. Listed above in the slide, you'll see the 7 dimensions of applied behavior analysis coined by an article written by Bayer, Wolf, and Risley, which demonstrates key concepts associated with ABA and that outlines proper practice and evidence-based success. These are listed as applied, analytic, behavioral, conceptually systematic, effective, general, and technological. So you can see in this graph, there was a study done, and this illustrates baseline and follow-up scores across each curricular area within the PERC, which is also known as the Preschool Inventory of Repertoires for Kindergarten. This PERC study consists of the curricular objectives for teaching the repertoires necessary for a child to excel in kindergarten, including the repertoires associated with academic literacy, communication, self-management for school self-sufficiency, social self-management, a community of reinforcers, like an inventory of the child's interests and preferences, and their physical development. That is, the assessment covers what a child needs to be very successful in the school, the home, and the community. Baseline scores indicate 18 behavioral assets out of a possible 242. And in this study, following approximately 3 years of intervention, the participant reached 209 long-term goals across 14 areas. This assessment is based on behavioral analysis and pedagogical research. Curricular goals are then selected based on deficits identified in the PERC. So some ethical codes to keep in mind when using ABA include Code 1.01, reliance on scientific knowledge, where the focus will remain on evidence-based protocols, and this considers use outside this realm to be unethical. ABA efforts are strictly enforced to stay within the realm of evidence-based practices and designed to treat those with ASD as well as related developmental or behavioral disorders. Another code to focus on is 1.04, integrity, where this is placed on the character and actions of the behavior analysts. Integrity in their work, including data collection techniques and adherence to treatment strategies and follow-through of treatment plans is expected. A final code to consider is 1.05, professional and scientific relationships. So services are performed in professional and scientifically based environments. Client differences are always taken into account when developing treatment protocols to include gender, race, religion, and any other cultural boundaries specific to the client. These differences also entail the range of severity on the autism spectrum, meaning that the interventionist is expected to take into account their individual abilities and deficits and implement treatments catered to the individual.
Thank you so much, Ina. We are going to open up the floor for questions again.
Okay,
Ladies?
so I have a question. According to Sandoval, Norton, and Scheddy, ABA causes unintended but damaging consequences such as prompt dependency, psychological abuse, and compliance that tend to pose high costs on former ABA students as they move into adulthood. Furthermore, little evidence of prompt fading to decrease this kind of dependence is shown. Is prompt dependence a valid concern for this therapy, and how do ABA therapists combat it?
Okay, so prompt dependence is a valid concern, but there are measures in place supported by research that work to alleviate and eliminate these concerns. These include techniques such as prompt fading, extinction, and chaining procedures, just to name a few.
So I also have a question. Research indicates that efficacy in ABA treatments only with those who have a measurable intelligence quotient, so known as IQ. So typically at 70 or above. So many studies on the effectiveness of ABA use an IQ to measure efficacy or as an inclusion criterion. So which means that children who are nonverbal, particularly those deemed as lower functioning and untestable, are excluded from these studies. So how can we be sure that ABA is an appropriate therapy for the treatment of lower functioning and nonverbal individuals with autism?
Okay, that's a great question. So ABA does not rely solely on verbal prompting for behavior modification. Prompts can be given visually, with or without prompts, hand-over-hand mocking movements for the client through the use of specialized communication technologies, and as well as nonverbal cues such as sign language or variations of it designed for those clients with disabilities. Some examples can be picture boards or little talking devices that look a lot like tablets. Research on ABA shows no significant differences in those that are verbal over those who are nonverbal in demonstrating general efficacy of ABA on the whole.
I have one more question. So Pierce and Epling state that the focus of ABA on socially significant behaviors is highly subjective. Who decides what these behaviors are and why children are being taught them? What happens when a mistake is made?
Great question. So socially significant behaviors can change cross-culturally, geographically, they can be gender specific and very ethnically diverse. All these aspects need to be taken into consideration when developing a behavior change plan in accordance with ABA ethical guidelines and evidence-based practices. This focus aligns with the BACB Code of Ethics, specifically Code 1.05, Professional and Scientific Relationships. I believe we discussed that one a little bit earlier. And so if mistakes are made during analysis focused on social significance, alterations to treatment plans can be made to better suit social and pragmatic needs of the client and caregivers. Nothing is set in stone. The program can change as the client goes along and behaviors can change too.
Perfect. Thanks, everybody. We are going to move on into the question and answer portion of our presentation, and then we're going to move into our conclusion. So the first question that we have is, how does your topic approach the core ethical principles? So the core ethical principles are do no harm, respect autonomy, benefiting others, being just, being truthful, according dignity, treating others with caring and compassion, pursuit of excellence, and accepting responsibility. This topic relates directly to these principles individually and as a whole. Individually, all of these models address quality of care issues pertaining to children with autism. And by doing this, they attempt to provide children with the best possible care in hopes of giving them the maximum opportunities for success. While working in this field, we attempt to do no harm, meaning that we consider what course of treatment would be best beneficial for our patients. We respect our clients' autonomy and promote their independence as we work to increase their level of self-sufficiency. All of the models discussed today were designed with the primary goal of benefiting others, as well as being just to our clients and being faithful to the goals of their treatment. While according dignity through these models, behavior analysts promote their clients to be treated with dignity and respect at all times. We do this by treating clients with care and compassion and the pursuit of excellence in our skill. All three of these models not only work to best serve clients with autism, but also to accept accountability when the best outcome has not been reached by continuing research and to modify their methods. So the next question that we have is, what personal experience do you have with this situation? And so as a group, as a whole, all 4 members of this group have experience working with individuals who have been diagnosed with autism spectrum disorder. We're all confident in the applied behavior analysis model and employ it on a daily basis to better the lives of our clients. Besides being familiar with applied behavior analysis, several clients that we work with also receive medications in order to reduce the symptoms that they feel. For example, it's not uncommon for medications that reduce impulsiveness and aggressiveness to be used for children who engage in those behaviors regularly. Furthermore, experience difficulties with sensory input is also very common, and there are a variety of treatments that can be used within the ABA model to mimic sensory integration therapy. For example, weighted blankets and coping methods are commonly recommended to clients who experience sensory issues. We believe that all 3 models that were discussed in this debate should be used together in order to give the best quality of care for children with autism. And although we all directly work with ABA services, we have all witnessed how these 3 models can be used together for the best possible outcomes. Our final question is, how does consideration of this topic enhance the practice and or address current issues? So that's a really good question too. The consideration of this topic can enhance the practice of treating individuals with ASD by creating awareness and alternative treatment therapies. Because continued research as well as continued education are so important, the knowledge of alternative treatments for children with autism can help behavior analysts find new and better ways of treating clients, as well as giving ideas for future research. This can also help address current issues in the field by exploring the advantages and disadvantages that are in all the models we discussed. Sometimes when you work within a particular field or in a particular model, it's hard to remember that there are other methods that are available for treatment. Some which might propose a greater benefit to your client than the method that you're currently familiar with. Perfect. Thank you for the questions. And then in conclusion, as I just stated, we believe as a group that in some situations, the 3 models can be used together to best benefit clients. First, we need to make sure that there are no medical issues, and if there are, they can be treated with the medical model. Medical treatment can also help keep under control some other behaviors such as anxiety, aggressiveness, or SIB. They can be very helpful. Having those behaviors under control allows behavior analysts using the applied behavior analysis model to work with people with autism to increase appropriate behaviors and decrease maladaptive behaviors. Although the sensory integration therapy does have a limited and non-conclusive effect, it can be used as a component like within ABA of treatment for individuals to address sensory issues and improve gross and fine motor skills. So that one can be very helpful too. Finally, we'll move on to our references. And thank you everyone for watching our debate.